So just as a first time, male Botox user, I guess my question is, will I look fake or will I look strange?
Okay. So you're definitely going to look better, right? You're going to look different because you're not going to have all the movement, right? It doesn't mean that you're going to look fake, but you're going to look a little bit younger, I will say, because you're not going to see all those little lines. You do have a little bit of asymmetry in your eyes, which is very normal, okay? You have these brows a tiny little bit lower, and these eyelids, it's a little bit lower as well. So with Botox, we can play with the brow positioning a little bit. We cannot change the eyelid positioning with Botox, okay? But we have products or medications that can help you with that. So we'll talk about that too. But definitely we can play with the brow placement, okay? And how we treat your forehead. With males, just like we were talking about last time, right? The pattern of injection for a male is different than the female, right? Males have their brows a little bit positioning more kind of like flat than females. So the pattern that we inject foreheads for in crow's feet as well, it's a little bit different. So right now we're going to do your markings, and then we're going to use Jennifer as a model too, and we're going to do her markings just so we can compare kind of like the differences in between female and male. Okay.
Perfect.
Injection pattern. Any questions?
No.
Okay, so let me explain what we're going to do because you're a new patient, right? So right now I'm going to clean the area, right? We're going to just clean everything. And then we're going to do little injections. Remember that the injections that I'm doing, they're not targeting the lines that you have on the skin. They're targeting the muscles that are creating those lines when they contract. So they might not make too much sense, right? The little dots that I'm going to make or do, but remember that we're targeting that muscle, right? Right after the injection, you're going to see kind of like a little mosquito bite, okay? It's just the fluid that is there. So you're going to be able to see the little like bubble right under the skin for the first couple of minutes, completely normal. I tell my patients, don't touch it, don't rub it, don't press on it, don't massage it, don't put any makeup on top, don't touch your face for the first 4 hours, okay? The first 4 hours are the most important where we can still kind of like disperse that fluid into a different muscle group, and then we can create issues that sometimes we cannot fix, okay? Remember that the muscles in the face are practically touching each other. So we really want to keep that product exactly where we put it, because if we press on it and we disperse it into a different muscle group, then we can create like issues, okay? So don't touch your face, don't lay flat on your back or lean forward too much for the first 4 hours, okay? So upright position, no touching, okay, for the first 4 hours. And then after that, just be very gentle to your face for the first 24 hours, okay? We don't want to do facials, massages. We don't want to do anything crazy, okay, in your face. Don't do a heavy exercise or heavy workout either for the first 24 hours, okay? Super simple. And then after that, right, you're not going to see any of the results right away. Today, nothing. Tomorrow, nothing. Like nothing happened, right? With Botox starting on day 3 or 4, that's when you're going to start noticing a little bit of that result, kind of like barely starting 3 or 4, okay, day 3 or 4. And then after that, after day 4, you're going to start very slowly, very gradually noticing a little bit more improvement until it peaks at 2 weeks, okay? So very gradual, very slow, okay? So peak of the product 2 weeks. At 2 weeks, I will bring it back, okay, to do a little kind of like a follow-up, especially because it's your first time. Right? Okay. I don't do follow-ups with every single patient of mine, especially because they know what to expect now. But sometimes for new patients, it's good to have like a little follow-up after, because sometimes the patient is super happy with their treatment, but you as an injector, you know that you can make it better. So you can do a little touch-up here or there. Okay, so that I think that will be awesome. Sounds good?
Sounds good.
Okay, any questions?
No.
What an easy patient. Okay, so Jennifer, do you want to come? Let's mark the female first. With females, because we want to have that little lift, right, on the brow, we are going to inject their forehead a little bit different than we do males. And I know this is not the Allergan pattern of injection, even if I'm an Allergan trainer, right? I'm going to tell you what I normally do in the office, right? Jennifer doesn't have a lot of movement on the glabella because she has a little bit of the toxin still, but we're going to mark her, right? Like if we were treating her. And you know, glabella, we treat actually 2 different muscles, right? We treat procerus, it's kind of like a little triangular shape right there. And then we treat corrugators. Try to do your angry look. There it is. See a little bit of that shape. something that is really important, and I feel new injectors, sometimes I see them going a little bit too high on Proceras. And whenever you inject too high on Proceras, sometimes you can get a little bit of the fibers of the frontalis that are still kind of like interdigitating to the Proceras. And if you stay too high on that Proceras injection, they may feel heavy, and you create kind of like that avatar look that you want to avoid, right? Because you want to give a lift on here. So my Proceras injection is a little bit lower, because remember that Proceras, it's kind of like almost down to the bridge of the nose. So you're not going to miss it if you go a little bit lower. So this will be my Proceras injection right there. And then belly of the muscle, right? And obviously you go with the muscle movement, right, of the patient. Jennifer doesn't have a lot right now because she has her toxin. So we're going to go with anatomy. So if you go with anatomy, it's going to be 1 centimeter above the orbital rim, and it's going to be aligned with the inner canthus. Okay, so that's going to be your belly. Remember, the belly of your corrugator is going to be your deeper injection, right? And then the tail of your corrugator is going to be your more superficial injection. The belly of the corrugator is where the muscle is attaching to the bone, and that's where you want to go a little bit deeper. And the belly and the tails are where it's attaching into the skin. So that's why you want to stay very superficial. And what I do to kind of like avoid going too deep on my lateral injections or the tails, it's going in an angle. And you're going to see it right now when I treat Dr. Sewell. Okay. And then, so that will be kind of like the pattern of the glabella. Okay. Proceras right there, bellies of the corrugators, and then tails of the corrugators. I recommended those by the FDA, 4 units on each one, okay, of the injections. For females, I don't go with the 20 units unless the patient is like a super, super strong glabella. I normally start with 16. And a majority of my females tend to do great with the 16. So I do 4, 4, 4, 2, 2. And that's what I do normally. Okay. Go ahead and raise your eyebrows for me. Okay. So for the foreheads, right? Foreheads are trickier, and that's why it's kind of like very normal or understandable that it was the last area to get approved by the FDA, because they're tricky, right? Everybody's going to be a little bit different. We need to play with the dose, right? With females, depending on how tall their forehead is, I do maybe 16, sometimes 20, sometimes 12. So that's the one that really varies on the amount. I feel comfortable doing 16 if you wanted to do it. Go ahead and raise your eyebrows for me. So what I do, I just mark kind of like with my fingers. I mark where those brows naturally peak, and I kind of like keep it right there. Go ahead and relax. And remember that frontalis muscle normally is bifurcated, right? So we have like a little area right here where we don't have a lot of muscle contraction. Now, there's some patients that you will see the movement right there. So you need to treat that area. But majority of the patients are going to be bifurcated. So you have to treat that muscle almost like if it was 2 different muscles, or at least that's how I do it. It normally starts or finishes right on the temporal crest. So where you see that little bony prominence where the temple starts, that's where it normally finishes. Go ahead and or attaches, and you can see exactly where the lines finish. Go ahead and raise. You see? Very good. My personal rule for forehead, so you don't droop anybody, is 2 fingers above their brows, right? So I never treat 2 fingers below that. So you're going to be treated in this area right here. And we are treating glabella anyway, so they are getting a lot of correction just on that central or medial forehead just because of the glabella injection. So go ahead and raise your eyebrows for me. Relax. Raise your eyebrows for me. Raise it. So this will be my pattern for you. So, and I will start you with 16 just to make sure that you're doing well with that dose, right? 2 units on each area. If you notice on the brow, right, I'm leaving a little bit of extra wiggle with this dot being a little bit higher, because the higher you are, the less movement you're taking, right? So you're going to leave a little bit more movement medially here so you can open that eye and you can bring that brow up. So that's why I'm doing this kind of like a tiny soft triangle on above the brow. For males, you don't gotta do that, right? You're gonna stay in a straight line because you're gonna keep the brows nice and flat for them. But for females, I always do that. I always stay a little bit higher right there. I think that's a beautiful pattern. Okay, give me a big, big smile. Okay, relax. So for eyes, right? For the crow's feet, the regular pattern that we normally see is just 3 little dots right there, 4 units on each dot. I normally don't do that pattern. Sometimes for female patients, if they are like maybe late 20s, early 30s, right, where they don't have a lot of lines, we can maybe do that. But my go-to for the crow's feet, it's a 4-dot pattern, but it's not. Relax. So if I'm treating with 16 units, which is kind of like my sweet number that I start my patients with, I do 2 units on each one, right? 2, 4, 6, 8 units on each eye. If I'm doing 20, I just do a little bit more on these 2, and then 2 units on this ones. So give me a big smile. Higher, higher. Like, there you go. So what I want to show them is, do you see these little fibers right here kind of like pulling down when you smile? Go ahead and there you go. I don't know if you can see it in the camera, but whenever they smile nice and high, you're going to see the fibers of the orbicularis oculi kind of like pulling down on this corner. That's why this injection is so important, because it's going to give them a nice lift right there. It's going to open their eyes as well whenever we do that injection right there. So go ahead and contract your eye a little bit more. There you go. I don't know if you can see those fibers pulling down. That's kind of like the best kind of like little brow lift. I see a lot of injectors going kind of like a little bit higher, kind of like right here under the brow. I've seen that injection going wrong really easily. So I just try to stay as safe as possible. This little dot is going to give you a nice little brow lift right there and completely safe. So that's the one that I like to do. So that will be an injection pattern for a female. Okay. And not all females are going to need that 4th dot. I think it's a nice way to blend kind of like the cheek to the eye muscle movement, especially for patients, you don't have it, but especially for the patients that when they smile, you can see kind of like a little line going down right here on the cheek. That's the perfect way to kind of like blend that line. And I tell my patients that line is not just the orbicularis oculi making that line. It's part of the cheek muscle movement as well. So I just explain to my patients that line is not going to go away completely. It's just going to be softer, right? Because we're doing that tiny amount of Botox right there. Mm-hmm. You have beautiful skin. There we go. Okay. So for male patients, we're technically treating the same muscles, right? But the pattern is going to be a little bit different. And I didn't notice any asymmetry. Your brows are very symmetrical, but so that's why we didn't talk about any asymmetry, but we'll talk about it with you. We're treating the same muscles, right? I'm not going to draw them again. I'm just going to have you go ahead and do your angry look for me. Angry. So that's something really cool. So if you notice, whenever you contract, go ahead and contract again. You see how the tail of his corrugator, it's kind of like more, kind of like standing up instead of laying on top of the brow. Go ahead and relax. So we're not going to treat like I mark you, right? There's some patients where the corrugator is going to be kind of like laying on the brow, which is kind of like the pattern that we just saw in Jennifer. But for some patients, it's a little bit higher. So that's why it's so important whenever the patients come in, even if I already treated them, right? Sometimes I tell my patients, wait until you start seeing a little bit of that movement coming back, because that is going to tell me more where to put that product. If the patient comes in and you don't see any of the contraction, right? Because maybe they did their treatment 3 months ago exactly on the dot and they still don't have a lot of movement. we normally treat with the anatomical injection points, which is a little bit the corrugator like laying on top of the brow, but not for everybody. So it's not for everybody. So for you, we're going to do the injections a little bit different. I normally keep my hands and kind of like mark almost with my hands. So when I put my hands in your face, I don't move them, and then I just treat, because I don't do the markings anymore. I just inject. Okay. But what I normally do, go ahead and do your angry. I do my fingers right there, and then go ahead and relax. And then I don't move my fingers. I inject you right there and then. So I'll inject glabella, proceros right there. Go ahead and do your angry again. Okay, relax. Belly right there. And tail, because we know that your muscle is not laying down on the brow, right? I'm going to go a tiny little bit higher. Right there. So that will be your glabella. And then for the forehead, we want to play with, and you can see his eyelid a little bit lower on this side too. So if you look straight to the camera, so you have a little bit of this brow ptosis, right, naturally, which is very common, right, in everybody. But you also have a little bit of eyelid ptosis. So if you see how much brown you can see in this eye compared to this eye, you see how that eyelid is actually a little bit lower. So for that, we have medications that can help. Ofnic is a great medication. It's kind of like in the newer side of it, and it works beautiful. So it activates that molar muscle that we were talking about last time, and it just opens the actual eyelid, so you can show a little bit more of the brown, and it works really nicely. It is a prescription medication, so you will have to send it to the pharmacy, and then the pharmacy sends it to your house. Go ahead and raise your eyebrows. But for the brows, even when he contracts, you see how he naturally is compensating with this brow a little bit more. It's lifting a little bit more because it's compensating for this eyebrow being a little bit lower. So the way that we play with asymmetries is by injecting on the lower side, which is his right eye. We're going to inject a little bit higher on that side. And after the 2 weeks are due, right, and you have full results of your treatment, you may still see a little bit more movement on this brow. That's normal, right? Because we treated you a little bit higher. And I tell my patients it's going to be like that because every time you come in, we're going to be playing with that asymmetry to the point that you're going to come back and we're going to say, which one was your lower brow? Because they're going to be so even, and we're not going to even remember which one was your lower one. But in the beginning, for the first 2 or 3 treatments, you're probably going to still see a little bit more movement on this brow. Super normal because we're injecting you in that pattern. Okay. So go ahead and raise your eyebrows. And you see how he normally peaks a little bit right there. So we really need to treat him nice and straight so he doesn't get like the spock. Go ahead and raise. So I mark with my fingers right there. Okay, relax. And then obviously my 2 fingers, right? So we're going to treat him around here. So where I put my fingers is kind of like where his natural peak of his brow is. And it's normally where that muscle is attaching into. So it's kind of like lateral. And I know a lot of injectors are afraid of that lateral injection. But if you don't do that lateral injection, then you numb everything in the middle, and then they end up with all this movement laterally, and that's the spock, right? So you do want to treat the lateral, you just want to stay a little bit higher so you don't make him feel heavy. Want to raise again? Okay, relax. So this one is your lower brow, so we're going to go a tiny little bit higher. And I'm talking about maybe 2 millimeters. It's not a big difference, but it makes a difference on the treatment. Kind of like that. Okay, raise again. So because he has a little bit of movement right here, right, because of a little bit of the receded hairline, remember to treat those areas too. Because if you treat just the medial aspect, then they're going to come back with what they call horns because they have just a tiny little contraction right here on that frontalis that you can still see. Go ahead and raise. Okay, relax. 2, 1 right there. Raise. Relax. Right there. Breathe. Relax. So we're going to do 20. And all the injections are going to be 2 units. So 10 units on this side, 2, 4, 6, 8, 10 units on this side. Almost like if it was a 2 muscle thing, because they have that bifurcation right there in the middle. And he's not the exception. Go ahead and brace. You see how there's no movement whatsoever right here. Everything is kind of like divided into little sheets. So for the forehead, right, we're treating it almost like if it was 2 little sheets of muscle, because it has that little bifurcation right here in the middle. So we're staying a little bit more flatter, right? A pattern, like a little bit more like a straight line for a male, except for him, because this is his lower eye, we're going to stay a tiny little bit higher on these 2, because we want to lift a little bit more this brow, right? And the higher we go, the less movement we're taking. So technically this brow is going to move a little bit more. And that's how we create that little lift whenever we have asymmetries. Go ahead and raise your eyebrows. You see how he has kind of like a little bit of muscle movement right here, all the way up where the receded hairline is. So we're going to treat that too, because if not, then they come back with horns. That's it. That will be the pattern. And it's 2 units per injection point. So it's 10 units on this side, 10 units on this side. Don't be afraid of the 20 units on the forehead. Especially for males, they tend to use a lot. So most patients need a little bit more than the 20, actually, especially whenever they have a little bit more movement right here. And then for the crow's feet, the only difference that we see with male pattern versus the female pattern is that sometimes we don't want to do that injection that is going to give you that brow, that corner of the brow lift that we were talking about, because that is kind of like more feminine looking, right? Go ahead and smile for me. So for males, we treat more kind of like in a straight line this way. Okay, relax. So instead of doing this, right, like if you were a female, right, kind of like more semi-lunar pattern, we're going to do more like a straight line on you. Right there. Instead of that semi-lunar pattern. That's it. Super simple. So for brows, you stay a little bit more like in a straight pattern, in a straight line. For the crow's feet, you avoid that corner one, and then more units. It's not super, super different than the females. Okay.
Perfect.
Are you ready?
Ready.
Okay. So we're going to reconstitute Botox. Okay. So Botox reconstitution on label. It comes in a 100-unit vial, right? So there's 2 presentations for Botox, the 50-unit vial and the 100-unit vial. The 100-unit vial, the on-label reconstitution is 2.5 mLs. You can use just normal saline, or you can use bacteriostatic water. Bacteriostatic water has shown less burn whenever it's injected. So that's normally what I use. So I do use bacteriostatic water. Okay. So 2.5 mLs. And one thing that I always mention with the Botox, do you see how I'm holding my needle, my syringe? I'm holding the plunger, because Botox comes with so much vacuum in the vial that if you let go of the plunger, it's going to take the fluid, like it's just going to absorb it right away. And you don't want to have a lot of like foam on the vial. You want to let go the product or the saline nice and slow. So just let it go nice and slow. And that's it. One thing with Botox, whenever, and I didn't show it, but whenever you open the vial, it seems like it's empty. So it doesn't have any powder in it. It just has like a tiny little smear on the bottom. Those are your 100 units of Botox. Okay. So, and once you reconstitute, you just swirl a little bit and it's ready to use. You don't need to do anything else to it. Be careful not to keep it too long out of the fridge in between patient treatments. I'm gonna open the vial, right? Because we're using the insulin syringes. So if we pierce the insulin syringe with the rubber cap, it will dull it. And remember, right, after we open it, it's not sterile anymore. So we have to be super careful just to keep the product as clean as possible. Because technically it's not sterile anymore. So we're going to do 20 units in your glabella, 20 on the forehead. Go ahead and smile for me again. We can do 20 on the forehead too. So the recommended dose is again 20 for glabella, 20 for the crow's feet, 20 for the forehead, and 24 for the crow's feet. We're going to do a little bit less than the recommended dose on his crow's feet just because it's the first time. And he doesn't have like a huge amount of movement on the crow's feet. So remember, with the 2.5 reconstitution that we just did, each 0.1 is going to give us 4 units of Botox. Okay. So if we are doing 20 units, we're doing a 0.5 ml amount of fluid. So each 0.1 is going to be 4 units. And whenever you're drawing your Botox, just try not to put your actual syringe in the fluid. Try to do just the needle, right, to keep it clean. And aspirate nice and slow. Remember, it's a tiny, tiny needle. So if you try to do it too quickly, you're going to start aspirating air. And then you just take longer. So just be patient. These are 0.5 ml insulin syringes. If I was doing the crow's feet, I would draw 2 separate syringes of, like if I was doing the 24 units on the crow's feet, I would do 2 separate syringes of 0.3 and do just one eye and one eye, if that makes sense. Because it will be a 0.6 ml injection if we were doing the 24 units. In this one, it's the product is good. We can just save it and put it in the fridge as soon as possible. And that's it. So we're ready for inject. Let me know when you're ready. We're ready? Okay, perfect. Chin, chin, chin. Give me your angry look. Okay, relax. Perfect. Okay. And I'm gonna inject through the little dot. Like I said, I don't mark normally in the office. If you're doing filler, I wouldn't go through the dot because the pencil could have a little bit of like bacteria in it. We cleaned you before, so you're nice and clean. And we're going to do 4 units on each one, okay? So there we go. So 4 units, it's a 0.1 on each injection. Remember the corrugator, the belly of the corrugator a tiny little bit deeper. You want to see that little welt, okay? It's just the fluid that is there. That's perfectly normal. And then when I do my lateral injection, I go in an angle, probably like a 45-degree angle, and just the bevel of the needle, just to make sure that I'm nice and superficial. So you want to see that little bevel. That's it. That's glabella. Don't touch it, don't rub it, don't press on it, remember? Okay. Don't lay flat, don't lean forward. That's it. So you want to see those little mosquito bites after. That means that you are superficial where you want it. The forehead, we're going to do 0.2s on each injection. So we're going to do 0.05, 0.05, yeah, on each injection. So 2 units on each one. There you go. And these ones, you can be nice and superficial. Remember, the muscles and the skin and the face are paper thin. So there's really not, unless you're touching the bone, there's no way to do it wrong. Go ahead and raise your hands. There we go. There's your husband. Relax. Perfect. And these injections that we did at the end, these nice and high ones, sometimes even if I don't see a lot of movement on that area, I like to inject in that area because of the newly discovered line of convergence. There's proof that whenever the muscle or the frontalis muscle, it's kind of like blending into the skull, it has a little area where the muscle it's pulling normally down. So if you inject that line of convergence, it's normally going to give you a little lift. So that's why I like to do those high ones right there. And you can read about the line of convergence is Dr. Cotofona, Sebastian Cotofona. Perfect. Okay. So we're doing 20 units and we have 4 little dots, right? So it's 10 units on each one. So I'm going to do 2, 4. So 2, 3, 3, 2. Okay. And I know it's kind of like hard to measure on the syringe. But we're doing 10 on each side. And the eye injections, the crow's feet injection, you want to be very, very superficial. Okay. These are going to be the most superficial ones. You're injecting 2 units on each one, right? The first one and the last one, and then 3 units in between. So you can have 10 units on each side. And maybe it's not. That's it. So you want to see that little mosquito bite, okay, on each injection. These are going to be the most superficial ones. Remember, if you go too deep on the crow's feet, you can target the zygomatic major and minor that are kind of like attaching into the lid, and then the patients come back with a crooked lid. So just stay very, very superficial, just bevel. And also, if you stay very superficial, you have less risk of losing the patient as well. So you want to see those little mosquito bites for sure. So same instructions, okay? Don't touch it, don't rub it, don't press on it, don't massage it, don't lay flat on your back, don't lean forward. No heavy exercise for the first 24 hours. That's it. Super, super simple, okay? And then obviously you're going to start noticing the improvement around day 3 or 4, okay? Very gradually, very slowly, every day, it's going to look better, 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 meaning less lines, right? Each day. And then 2 to 4 weeks for final results.
All right.
Okay.
So because I need to take it easy, I just need to avoid all kind of house chores and stuff like that, right?
You can still wash dishes. Just don't do vacuuming or anything like that. Well, you did great.
Yeah, that was easy.
Perfect. It's a tiny needle, so it's really not that bad. So I have everybody asked me about which is the best pencil. Believe me, I tried them all. And the one that works the best is the cheapest one. So Wet n Wild. That's the one that I like. And I like that it's a wood pencil because every time you sharpen it, you're kind of like cleaning it. Sometimes I see offices using kind of like the markers that the dermatologist will use. And I feel like you're touching the skin of different patients with the same marker, and it's just sharpen it. They're so cheap. But they mark so well. You could see right now in the video. I mean, it's just, you just touch the skin and it marks really, really well. And then it cleans really easily too after. So that's the one I use. So we have a question asking when is it that we use a higher dose on glabella for a male patient? I normally treat him with the 20 or sometimes 24 units as a maximum in one sitting. And then I have them come back. I have them come back 2 weeks later and reassess how much movement they still have left. And I tell patients, I do have some male patients that require more than the 20 for sure. I normally do those 24, have them come back in 2 weeks, reassess and add then. And sometimes I add 10, 12, 16 units more. I wouldn't feel comfortable doing more than 24 in one sitting, honestly, because I just don't want the fluid kind of like to go into a different muscle group. So in those patients, they know that they need to come back every time they do their treatment. Like if 24 units is not doing the trick, they know that they need to come back 2 weeks later and do a little bit more. And in that case, they obviously you charge them for it. Normally, when I do touch-ups, I don't charge. I just, whenever I see my patients for the first time, especially if it's a female, I start them with maybe with the 16 units per area, and then kind of like reassess 2 weeks later. If they need more, I don't charge for that touch-up, right? Let's say we did 16 in the beginning and then they end up needing 4 more. Now we know next time, whenever they come back 3 months later, they're going to need the 20. So I treat them with the 20, I charge for the 20, and everybody's super happy because they don't have to be paying for that touch-up.
And then what about, one question I have is, like basically for men, when they first come in, I imagine there may be even like a level of shyness or stigma or something. Like, do you find that often, or is it maybe not?
I feel like once they're sitting in the chair, they're kind of like, they're there, they're ready for the treatment. I see that more kind of like maybe like if I'm at a party and I'm talking to the couple, right? Wife and husband, and they are a little bit more reluctant to kind of like the talk. But once you have them in the chair, they're pretty receptive. Yeah. I haven't had any issues with that. Yeah.
What do you think is the most common question you get from men that are seeking neuromodulate or even any aesthetic treatment?
Does it hurt?
Does it hurt really?
I have my MA kind of like at the door waiting for me if I call her. Whenever I have a male patient, they tend to have a little bit less of that pain threshold is a little bit lower for them. So I think does it hurt is a question, and like the question that you just had, like, is it gonna look natural? Because they definitely don't want to look unnatural. And I feel like the natural portion of the treatment is mainly of placement. It's like a placement thing. Where you put that Botox, it's going to make it look more natural or more kind of like overdone, depending on the placement, more than the dose.
Like you said a minute ago, like the dosage is more important about the placement. So you could actually have 2 different providers get a similar treatment. One could actually be using more dosage. But the things that the dosage might go to areas, for example, like where the bifurcation is, and it doesn't do anything, you know?
I feel like, and I'm so adamant about this, dose equals duration. So if you go and do a very light dose, you may still see good results after, but then they're going to start fading quicker. And I feel patients, because they start fading quicker, right? They feel the need to get treated again quicker because they have the movement back. And then I see places doing that pattern of very little, very often, very little, very often. And then I've seen resistance to it. Definitely resistance created because of that pattern of very little, very often. So I'm very strict with my 3-month rule at the office. I don't treat anybody if it hasn't been the 3 months. If they start having a little bit of movement before the 3 months, that means that they need more whenever they come back 3 months later. So I may increase the dose, maybe 2-4 units, something moderate, and that sometimes does the trick. Like for COVID, whenever we had COVID, right? For some patients, I didn't see them for 9 months or even a year. So whenever they came back, a lot of patients, and I heard a lot of injectors saying too that, oh my God, I don't know what's happening, but it's not working. Well, patients have a year of muscle strength, right? You're not going to be able to treat it with the same amount and get the same results as if the patient got treated 3 months ago. So that's why I try to explain to my patients, this is your first time, right? We're going to do these dose. You may still see a little bit of movement. Come back exactly 3 months later, because at that point, your muscles are not going to be back, right? They're not going to be fully moving. And we treat them with the same dose. So that dose is going to work better. I don't know if that makes sense, but
Yeah.
and you slowly tame those muscles, right? To the point where the recommended dose is doing the trick, and you don't have to go higher than that.
And that's because each time you use a neuromodulator, basically the
Mhm.
muscle's starting to weaken, and then over time it gets weaker and weaker. Is that
It's not getting weaker and weaker. We are treating the muscle before it regains the
I
strength.
see.
So
Okay.
if you stop doing it, it's going to regain the strength completely. So it doesn't get weaker. You just treat it while it's still weak.
So that way it keeps it maintained.
Exactly.
Okay.
Exactly. So you're getting the same result or even better result with the same amount of units. So what I tell my patients is give me a year every quarter. So especially that first year is very important to kind of like erase little fine lines that they already have. Give me a year every quarter. Don't try to do one treatment right now and then come back in 6 or 8 months, because at that point your muscles are it's kind of like doing 2 steps back front and then 2 back, and you're not getting anywhere. So, but if you stay on track, right, and you treat every 3.5, you're gonna get better results even with the same amount. I don't know if that makes sense.
It does.
And sometimes patients, like whenever they have been doing it like for a year, right, every quarter, they start telling me, "Is it lasting longer?" And I'm like, no, technically it's not lasting longer, but your skin is looking so good in between treatments that you can kind of like, if you want to, you can skip and do a little bit more, 3.5 or 4, right? Because their skin is looking amazing, even in between treatments. So, but technically it's lasting the same.
And you were saying with the year, every quarter, the first year. So
Mhm.
like when a new patient comes in, you say, hey, look, in order to get the result,
Yes.
basically you need to come every quarter this
Yes.
year. And then after that, we can start to reassess.
Exactly. And then after that, whenever your skin looks amazing, if you want to give it a little rest and come every 4.5, you can do that.
Okay.
Mhm.
Awesome.
Yeah. Mhm. But that first year, I'm very kind of like
Regimented.
yes, to get the best results.
So there's a great question. If the client needed more than 24 units in the glabella, and then they come back in 3 months, knowing that they require more than 24 units, would you have them come back in 2 weeks again for the rest of the dose? To say like if they needed an additional 12 of their first unit,
Yes. So I do the 24. And for those patients, especially, are the patients that I'm like, you have to be here in 3 months. Don't wait 3.5, don't wait 4. Come back in 3 months, because I can assure you, if they come back in 3 months and you do the 24, which is kind of like my most or the highest dose that I will do comfortable, you do the 24 units and they just got treated 3 months ago with another 24 units, those 24 units are going to work better. They're going to work better. So that's when I'm very strict with my patients. Whenever I see them having to come back for more, let's say the patient doesn't or can't or doesn't want to, right, come back 3 months later, and they do come back 8 months later, I still split the dose. And they know, right, your dose is 32. So they come in, they do the 24, they come back 2 weeks later, and they do the rest.
Like with regards to male patients, because we're starting to see more and more of these coming in, and more trend of this. Are they also like looking into filler? Are they looking into other?
Yeah, definitely.
What do you think is like the most popular thing for the filler?
I think cheeks. Because again, they're noticing the face changing, right? But they don't know what it is. So like I said, whenever I do my consults, I always do the full face consult. So even if they're not interested in cheeks, I normally tell my patients, listen, you're sitting here, right? I'm going to give you my recommendations, what I would like to do on you. It doesn't mean that you have to do it, right? It just means that in a world of unicorns and rainbows, right, where budget is not an option or anything else is not an option, this is what I would like to do on you. So I go ahead and write down everything. I explain why, right, the cheeks will be good for them, or the chin or the jawline. Especially right now, the jawline is like, because of the Botox being just released, they have so much kind of like advertising on it. So a lot of patients have been coming in, male patients have been coming in asking for jawlines and chins. And as we know, right, we have to treat cheeks first, because we cannot give improvement over here, or we cannot give the best improvement in the lower face if we don't treat the mid face first. So it's just a part of the process of the consultation and explaining why and everything. So, but I think cheeks it's a very, very nice treatment for everybody.
And so for most men that come in, you do the full face consult, you'll even recommend, so if someone says, hey, I'm interested in my jawline being, more cut,
sharper or whatever.
Then you'll still do the full consultation, recommend, treatment of 5 lines with neuromodulator, then You
Yeah.
do mid-face with.
So I explain to my patients, there's 3 signs of aging, right? One of them is the fine lines and wrinkles, which is what we are treating and preventing with Botox. One of them is volume loss, which is the filler, right? Mid-face, lower face. And one of them is the skin. So, and that's why we always recommend to do a little bit of everything, right? Botox for the upper face, filler for the mid face, but also laser or microneedling or anything like for the skin in general, like pigment, fine lines and wrinkles in the surface. So I just do the full consult, explain everything, write down my wish list, right, of what I would like to do on them, and then they decide. And I feel like they appreciate that. They appreciate that full consult, that full face consult, and you're kind of like planting that little seed, right? Somebody told me already, and then you do their Botox treatment and they're super happy with the results and they kind of like trust you already. So they're kind of like more inclined to kind of like jump into the filler. That's how I feel.
For patients where you really cannot see the tail.
Cannot see the tail. Okay. Okay.
That need to be treated. How would you treat to ensure you don't get the front callus?
So you stay very superficial. Whenever you don't see the muscle contraction at all, I normally stay. So you know that there's always going to be some anatomical variations, right? Like we saw on Dr. Sewell, right? That his corrugators are a little bit higher. Majority of the patients are going to be like Jennifer's. So they're going to be kind of like more laying on the brow. So if you don't see the muscle contraction, you go with anatomy, right? So you're going to treat like if they were kind of like laying on top of the brow. Angle your needle, right? Just bevel of the needle, stay very, very superficial. So you know that you're kind of like in the tail of the corrugator and you're not going over it. Or bypassing it. And then I normally tend to do a little bit less on the tails just to be safer, especially for females, right? And that's why I do kind of like that 16 dose where I do 4, 4, 4, 2, and 2, and just kind of like very angled and just very superficial. But you go with anatomy if you don't see the movement.
Do you ever use your hands there, kind of the way you were doing before, to feel if you can't see?
Yeah. And most of the time you will see a little bit of that shape, right? Even if they don't have the full muscle movement. For those patients, if they're coming in exactly at 3 months, especially females, that they tend to do a little bit better, right, with less units. Let's say they're coming back at 3 months and they still don't have a lot of that muscle contraction. Those patients are recommended to wait a little bit longer. Just like the other ones, I tell them, don't wait. These ones, I tell them, why don't you come back in 3.5 months? I think we can pull 2 more weeks out of this treatment. And they do that, and you can see a little bit better of that muscle contraction, that it's barely starting, but it's safer for you as an injector because you can see better the muscle contraction. So that's what I do. Even if you don't have a lot of muscle contraction, right? You can kind of like see the shape of it. I know exactly where the tail is right here, right? And right here, because I can see kind of like the shape. You can also kind of like with your hands kind of like move as well. And you can see kind of like the bulkiness right here of the tail. So kind of try to mimic the contraction of that muscle. Now, the other way that you can do it as well, if you don't have any movement, is going with anatomy, right? We know that, the belly is going to be 1 centimeter from the orbital rim aligned with the inner canthus, right? The corrugator, the tail of the corrugator is going to be almost finishing mid-pupillary. So open your eyes for me, Jennifer. Look straight. So if you don't see any movement at all, stay with anatomy. So the tail of your corrugator is going to be aligned with mid-pupillary. So, and it's kind of, I don't know if you can see it in the camera, but it's exactly where she has that little tail right there. So you can really tell right there and right there. And remember that with your 2.5 ml reconstitution, okay, each injection is going to spread 1 centimeter apart. And that's why it's so important to stay with the reconstitution that it's recommended by the FDA, right? Because we know how it works. So every injection that we do is going to spread 1 centimeter around. So imagine kind of like a little penny surrounding, because a penny is 1 centimeter, right? So imagine like a little penny surrounding each injection. So whenever you do the tails, you don't want to be right in the border of the tail. You want to stay a little bit more medial because you're still going to have some dispersion, right? So imagine kind of like that whenever you treat your whenever you do your Botox. Imagine like a little penny surrounding each little injection. And you know that you're going to have everything covered. I don't know if that makes sense. And that's why, and we know that if they reconstitute with more, the more fluid you mix in the vial, the higher that dispersion is. So you don't want to droop somebody, right? Trying to put more fluid in the vial, because it's going to disperse longer and it's going to go over the muscle that you're trying to treat. And that's why it's so important to stay within the reconstitution rates of the recommended from the FDA. I don't know if they saw when I opened the vial. These ones are great. I have them too. I use them a lot. They have the small little kind of, it's like a plier really. And they have the small one is a 13 millimeter and the big one is a 20 millimeter. And it opens the vial so easily. So if you're using the insulin syringes, this is like a lifesaver. Before I used them years ago, right? I used to open the vials with like scissors and like the staple removers and forceps and so many times I was like about to injure myself. So this is like, you have to have one. And I got mine in Amazon. I don't know where you guys got this one, but Amazon, it's a vial decopper. Let's see.
Well, you have a lot of people. Keisha was saying it's great. Robin said she loves it. I asked them if we'd like to have more trainings like this when they're live. And they said yes, they love it. Keisha said yes, please. Robin said yes.
Awesome.
Thank you guys so much for the feedback that helps us. We're always trying to make things better. And one thing I love about Onna is not only she's just like a little package of happy energy, but she has so much experience. I feel like you could ask her you can ask her questions, and so often like there's so much because she's seen so many patients over so many years, like it's just such a wealth of information,
And again, it's just the way I do it, right? It doesn't mean that you have to do it this way. It's just the way that I've been doing it for years. So hopefully I can avoid the boo-boos that I made in the beginning. I can avoid them for you guys. You can learn from my boo-boos.
All right, guys, we'll definitely have more. Thank you so much. Thank you for joining.
Bye, guys. Thank you.